Hey there everyone, my name is Andrew Shedd with Sonoed, and today we're going to be talking about the assessment of the kidneys with point of care or clinical ultrasound in the emergency department, and why would we do that, and what are the benefits of using point of care ultrasound when you're evaluating your patient in the emergency department. We're going to show plenty of images both of the normal kidneys with a review of the anatomy, and then also what the kidneys look like on ultrasound. We'll talk about how to scan the kidneys and bladder. We'll go over some basic pathology and then do a brief literature review. Most commonly in the emergency department, we're going to be using ultrasound when our patients come in with some sort of pain, be it abdominal pain, flank pain, or back pain. But occasionally you might use this ultrasound if they're having hematuria or urinary retention. The benefits to ultrasound are many. First and foremost, for this particular ultrasound tends to be even more sensitive than CT for hydronephrosis, and it of course spares them any ionizing radiation or IV contrast that they would have if they had a CT scan or an IV pyelogram. Ultrasound is also reliable, efficient, and reproducible. The downsides to renal ultrasound are that it does not always identify the cause of the hydronephrosis if you see it, and in the setting of an obstructing ureterolith, ultrasound will usually not see the stone in regards to its size or location unless it's really proximal in the ureter. Here's a very basic overview of the normal anatomy of the kidney. You'll see in the center is the pelvis with its surrounding major and minor calyces, and then you'll see the renal cortex around the periphery with its renal pyramids, and out of the hilum come the renal vessels, including the renal artery and vein, and the ureter. Whenever we're scanning a solid organ structure, we want to scan it in two planes, both its longitudinal axis and its short axis. And in the kidney, that's usually going to be the coronal plane and the transverse body planes. It's also important to note that you always want to examine both kidneys, even if the patient is only having unilateral symptoms. This is because mild hydronephrosis can be subtle, and it's good to compare the symptomatic side of the patient to the asymptomatic side. I also recommend examining the bladder, and this is of particular importance if you do see hydronephrosis, because the next thing you want to do is make sure that it's not post-obstructive. You'll see that the long axis of the kidney is as we would expect. It's more ovoid in appearance, whereas in the short axis it's more rounded. These images should appear fairly similar to your FAST exam, except for the kidney is more centered on the screen as opposed to Morrison's pouch or the splenorenal space. I tend to start on the asymptomatic side when I'm scanning these patients, and that's because I want to see what their asymptomatic kidney looks like before I look at the symptomatic side, but that's just personal preference. I also tend to always examine the kidney in long axis, which I think is the most common approach, as it tends to be easier to find, and then I rotate the probe in 90 degrees before fanning through it. You'll recall that the indicator on the probe is always going to go towards the patient's head or towards their right. And you'll also recall from your FAST ultrasounds that the left kidney tends to require a more posterior approach than the right kidney. Again, when you're looking at both kidneys, compare them side to side, assessing for even mild or subtle hydronephrosis. Here's an example of a scan through the longitudinal axis of a normal kidney. You'll see that in the periphery or the cortex of the kidney there's prominent renal pyramids which appear like inverted triangles and are anechoic. And then in the center of the kidney you'll see the renal pelvis and calyces, and there's no fluid collection within those spaces, and so there is no hydronephrosis. Next, you'll see a scan through the short axis of the kidney, and again you'll see that the renal pyramids in the periphery are very prominent in this patient, but again there is no central hydronephrosis of the renal pelvis or calyces. Here's more still images of normal kidneys. Make sure that you can identify the renal pelvis and calyces in all of these images, and make sure your eye can pick up that there's no hydronephrosis. So what are we looking for in terms of pathology when we do a renal ultrasound? Well, predominantly we're going to be looking for hydroureter and hydronephrosis, which is fluid collecting and filling within the ureter and the renal pelvis and calyces. But there's a few other things you may see. You may see nephroliths, which are small stones in the renal parenchyma that will be hyperechoic and tend to shadow, or you may see stones in the ureter as well, particularly if they're very proximal or in the renal pelvis itself. The distal stones tend to not be seen unless you're really good at following the ureters down. Hydronephrosis is graded somewhat subjectively from mild to moderate to severe and anywhere in between. I tend to think of mild hydronephrosis as filling the renal pelvis and calyces but without dilating them, and moderate as dilating the renal pelvis and calyces, and then severe is when the renal cortex and parenchyma starts to be obliterated. Here's a couple examples of mild hydronephrosis. You'll see in this video that I've put up a normal image on the left and the pathologic one on the right. This is mild hydronephrosis. Make sure your eye can pick out the confluent fluid within the renal pelvis that's starting to fill the calyces. Here's another example of mild hydronephrosis. Again, you can see that there's fluid collecting within the renal pelvis, and this time I'm going to show an arrow just to make sure that you can see it. A couple more examples. In the upper left-hand corner is the ultrasound image itself, and in the lower right-hand corner I've put stars in where the hydronephrosis is. Make sure your eye can pick up on this, as this is very subtle. And here's one more image. Again, very subtle finding of hydronephrosis within the renal pelvis. And here it is in short axis. Anytime you're assessing for hydronephrosis, or any pathology for that matter in a solid organ, you should be able to see it in both planes if it's truly there. So use your transverse or short axis of the kidney to confirm that the fluid you're seeing is actually within the renal pelvis. Here's an example of moderate hydronephrosis. In the left-hand corner, you see the longitudinal axis of the kidney, and in the lower right-hand corner, you see the short axis. Again, that fluid that's filling the renal pelvis and calyces is visible in both planes. Here's one more shot. This is a still image of moderate hydronephrosis. And then a couple more images, and in this case I would call this moderate to severe, as you're starting to see thinning or obliteration of the renal cortex. Next, we're going to see a great example of severe hydronephrosis. This should not be missed, as the more pronounced the hydronephrosis becomes, the easier it is to pick up on. And this patient has severe dilatation of the renal pelvis and calyces with thinning of the renal cortex. A few other things you may find on the renal ultrasound. First is going to be a renal cyst, and these are simple fluid-filled anechoic cystic structures within the renal cortex that are thin-walled. They tend to be peripherally located, and because they're fluid-filled, they generally will exhibit that posterior acoustic enhancement. Here's a few examples. Now, if the patient is not aware of these, because I'm not a radiologist, I tend to ensure that they have close outpatient follow-up for a confirmatory study if I'm not getting one in the emergency department. If they have known renal cysts, and specifically if I have prior imaging to compare these to, then I may be able to ascertain that these definitively are renal cysts. But if they're a new diagnosis, I personally do not make that in the emergency department without confirmatory imaging. Here's a few more examples of renal cysts in both axes. And then here's an example of polycystic kidney disease. This can be challenging to differentiate from severe hydronephrosis at first glance, but this tends to be a relatively asymptomatic condition in that this condition typically doesn't present with acute pain and is a more incidental finding. Here's a video of the longitudinal axis of a patient with polycystic kidney disease in their right kidney. You'll see that these structures are located throughout the kidney. They're all cystic with thin walls, as opposed to that severe hydronephrosis that we saw earlier. There's a few more things you may see on the kidneys when you're doing your ultrasounds. If the patient has pyelonephritis, particularly if it's severe, the cortex of the kidney may become hypoechoic. There's also a condition called emphysematous pyelitis, where the patient has an infection of their kidney with a gas-forming organism, and this can give you a reverberation or comet tail artifact down from the cortex of the kidney, and is something you definitely would not want to miss. Your patients with end-stage renal disease or advanced CKD may have small hyperechoic kidneys that are somewhat atrophic. And then lastly, you may see stones within the kidney or ureters themselves, or you may see a mass. There's one study I want to mention, and if you haven't read this study, I would encourage you to look it up and get the full text and go through it. There was a great study published in the New England Journal of Medicine in 2014 that was entitled Ultrasonography versus Computed Tomography for Suspected Nephrolithiasis. And this is probably the largest study to date wherein the three arms of imaging modalities for nephrolithiasis were compared head-to-head prospectively. And those were point-of-care ultrasound, radiology-based ultrasound, and CT. And the takeaway from this was that obviously the patients with ultrasound had less exposure to radiation, but specifically the patients that had bedside ultrasound spent much less time in the emergency department, and altogether the diagnostic accuracies were exceedingly similar, as were the patient outcomes. And so if you've not read this study, I would definitely encourage you to look it up and go through it, as it was very well done. So in summary, we're going to use renal ultrasound at the bedside to assess for hydronephrosis. This is great for patients who have a high index of suspicion, particularly those who've had prior obstructive ureteroliths and have similar symptoms. Recall that you always want to assess both kidneys. Look closely for mild hydronephrosis, comparing the symptomatic side to the asymptomatic side, and be aware of other pathology that you may see and its limitations.
Thanks for your time and attention to this lecture. I do hope you found it educational and informative, and as always, please feel free to contact me with any questions or concerns, and please check back in the near future for more lectures.